So thank you for so much, Dr. Kim, for the invitation to present today. I'm going to be talking a little bit about the state of the art from a medical oncology perspective, looking at the new staging with the ninth edition and its impact on management of thymic tumors. I have no relevant disclosures. So Professor Van Ramdonk, Dr. Shepard did an excellent job of sort of going over some of the salient changes that were made from the eighth to the ninth edition. So I won't belabor this slide, but just to kind of summarize those changes, including changes in the T1 category being subdivided and removal of the mediastinal pleural involvement, the inclusion of lung and phrenic nerve that was previously T3, now being T2. No changes in the staging grouping, and then N and M components were largely the same. And this was presented very eloquently by Dr. Ruffini, Professor Ruffini, at the ITMIG annual meeting in 2023 in New York, going over some of the proposed changes that were going to be made. And I think one of the highlights of this was that the changes in the T portion of TNM would largely help with discrimination in terms of outcomes based on that revision. And you can see that very clearly here. Particularly in thymoma, you see a really great distinction between the categories of T1A, T1B, T2, T3, and T4, and similarly with thymic carcinoma. So we're getting better discrimination. It's helping us to understand disease biology and sort of address it in a more meaningful way when we think about what the treatment options can look like. And then this was also presented at that same meeting, looking at some of the concordance. Clinical staging remains such an important part of our treatment decision making, particularly in the absence of pathologic staging, which is sometimes limited for providers as we're moving into planning what treatments are going to look like. And so we can see that there's pretty significant concordance, great concordance with clinical and pathologic tumor size, but the gaps really remain in terms of nodal staging. And you can see here in the panels up top, whether it be thymoma or thymic carcinoma, once we get into the N1 and N2 space, particularly with thymoma, you can see that there's a lot of discordance. And that's really owed to our clinical tools like PET CTs, which sometimes don't discriminate quite as well in terms of nodal involvement, particularly with thymomas. And certainly one of the other key aspects in the lack of concordance across these features is really the limited clinical stages within the database that was used to develop these recommendations at less than 10%. So certainly an area that we can improve upon in terms of having the numbers available to us to make really better, more granular recommendations. But as was described before, I think one of the key points in all of this is the multidisciplinary approach to addressing resectability, particularly when we talk about the changes in the TNM staging and the relevance of additional treatment options like neoadjuvant treatment or even definitive chemoradiation. And certainly having a biopsy on hand to help inform those types of decisions when we're thinking about neoadjuvant therapies or definitive chemoradiation is obviously necessary to make those decisions. So just to go through the management of locally advanced disease, I tend to bucket it into two categories, as does the NCCN guidelines, looking at an unresectable disease versus borderline resectable. For unresectable, I tend to think of systemic therapy with chemotherapy versus concurrent chemoradiation. And the next couple slides, I'll talk a little bit about some of the studies that have helped to inform that decision making. And certainly in borderline resectable cases, we think about neoadjuvant, not just systemic therapy, but potentially neoadjuvant therapy in general, including the use of radiation. And I'll talk a little bit about one of the study that sort of broached that idea. So for outcomes of concurrent chemoradiation, this was a prospective study looking at 56 patients with limited and advanced unresectable thymic tumors with a good representation across the thymic histologies with 22 thymomas and 34 thymic carcinomas. The patients in this study had disease within a field of radiation and were subsequently treated with cisplatin and etoposide, along with concurrent IMRT for 2 cycles, followed by 2 additional cycles of chemotherapy after. And you can see the response rates are pretty substantial, with an objective response rate of 85.7%. 5-year PFS and OS are 29.5% and 56.2% respectively. So there's always areas of improvement, but ultimately this does highlight the utility of concurrent chemoradiation in patients who are deemed unresectable and a potential option for those patients. I'm going to switch gears and talk a little bit about the pros and cons of neoadjuvant therapy. as it does help us inform decision making regarding particular patient populations. And so some of the pros, as every medical oncologist knows, is that at the onset of the diagnosis and treatment, patients are typically at their best performance status and are suited to complete the therapy. And so that's a rationale for really being aggressive up front with trying to go for resection or other locally ablative therapies. We see increased rates of R0 resection, and the potential extent of disease can change too with neoadjuvant approaches. So there have been a number of cases that we've seen where we've gone from, looking at extensive reconstruction of vessels to being able to move into a place where we can do less of that and less morbid surgery, and sometimes even move into a minimally invasive surgery if the disease allows it. But I think one of the most important parts of neoadjuvant therapy, at least for the medical oncologist, is that we're able to get a really deep sense of the biology of the disease and sensitivity to systemic therapies. I think this, for the medical oncologist, this really gives us a sense of where the biology is and what subsequent therapies may be useful going into the future. And so we sort of plan ahead just in case about what the next steps may look like based on response to the disease that we see in preparation for neoadjuvant and then neoadjuvant therapy and then surgery. There are certainly limitations to neoadjuvant surgery, neoadjuvant therapy. It's not all pros. And certainly there are times where we delay surgery in what would be considered a borderline resectable situation that can ultimately lead to other issues. And in particular, I talk about adverse effects that may lead to, cancellation of the surgery, hospitalization, or even death. And certainly these neoadjuvant approaches aren't foolproof. They're not 100%. And so there's always a risk for progression of disease precluding definitive resection. And so just to highlight that, you can see the overall response rates that are across the studies that looked at neoadjuvant approaches for borderline or potentially resectable disease, not 100% by any means. And so, as I alluded to, there's that risk that we just never get to the point of going to surgery, which is ultimately the curative modality of treatment. But you can see here response rates are quite good. And so in a study by Kim, looking at 22 patients with thymoma with combination chemotherapy, you can see a pretty strong response rate, R0 resection rate, and 6 patients who experienced major pathologic response. This study over here also highlighted a very similar response rate, R0 resection, and 3 pathologic complete responses in a thymoma population. And then Park and Course looked at patients that included a good representation of thymic carcinoma too, with patients receiving cisplatin and docetaxel or cisplatin, etoposide, and concurrent RT. And you can see that though the objective rates are a little bit lower, which we could explain with the biology of the disease and the presence of thymic carcinoma, still having good R0 resections, and again, 5 major pathologic responses. So there is obviously a place for neoadjuvant approaches in managing locally advanced disease with the goal of optimizing surgery and potentially getting better outcomes as a result of that. So how do we manage metastatic disease? And I tend to tell patients that metastatic disease is not a single entity. It's not a monolith. It's a heterogeneous presentation, and it can go all the way from a spectrum of having, very limited oligometastatic disease with a couple of pleural lesions, all the way to something that's much more extensive. And so it's really important, particularly in this disease state, that we are using multimodality, multidisciplinary approaches to really personalize how we treat the patient. Because there are certain situations where surgery up front may be very reasonable. There may be situations for more extensive disease where systemic therapy is the right way to go. And there may be cases where a little bit of both is going to ultimately do the best for the patient. And so we're always surprised by how our systemic therapies work. We have very poor prediction models to say who's going to do well and who's not. And so there's a number of cases where we start with systemic therapy, we see a very brisk response to treatment, and then we ultimately can consolidate with radiation therapy or even surgery. And so on the right, we have a panel of a patient who had very extensive disease, and this is just highlighting a portion of that disease. But we can see that with neoadjuvant treatment, we saw a huge reduction in the disease burden. And so what was initially not thought to be neoadjuvant, ultimately with the great response that we saw, proved to be a neoadjuvant approach with a very long time period without disease recurrence for this patient's thymic carcinoma. So I think it was, it goes into showing that there needs to be a personalized approach for how we do things, though we use the guidelines as a starting point for making those decisions. I want to touch base very briefly on a couple of newer studies that have come out for disease in the metastatic setting, particularly with frontline treatment. So this was a paper by Proto and colleagues that was published in late 2024, looking at 35 patients with advanced treatment-naive thymic carcinoma, and this looked at the addition of ramucirumab, a VEGFR inhibitor, to what our standard treatment for thymic carcinoma is, which is carboplatin and paclitaxel, and this was for up to 6 cycles, followed by ramucirumab maintenance. And we saw that the patients, generally speaking, had a pretty advanced disease, with 85.7% having Masaoka stage 4B. And we saw a very impressive overall response rate, 57.6 in the blinded review, or 80% by investigator review. And that really does speak to a substantial improvement as we across the other studies that have previously looked at carboplatin and paclitaxel before. I will place a very big asterisk that we don't do cross-trial comparison. It's fraught with a lot of issues, but at the same token, without this being a rare disease, we're oftentimes comparing to historic controls, even when we're not really supposed to. And this looks at some of the survival outcomes that were seen by that study. And you can see the median PFS was 18.1 months, with a median overall survival of 52.3 months. So really, really very impressive. And its inclusion into the frontline treatment, I think, is something that's being adopted very readily, particularly when we think about the biology of the disease. We know that advanced thymomas and in particular thymic carcinomas have been shown to have pretty significant microvascular density and VEGFR expression, really giving a rationale for the biologically why the incorporation of a VEGFR inhibitor would make sense for upfront treatment and improved outcomes. On the flip side, I want to highlight a different triplet therapy that was recently published in March of 2025. This is looking at the inclusion of immunotherapy, immune checkpoint blockade, in standard of care chemotherapy. And so this was 48 patients with metastatic or recurrent thymic carcinoma who received a different triplet therapy with carboplatin, paclitaxel, and atezolizumab, an immune checkpoint blockade agent, with 6 cycles, up to 6 cycles, followed by atezolizumab maintenance. And so this patient population also had significantly advanced disease, with 52% having Masaoka stage 4B. And you can see from the PD-L1 expression levels that it was really representative across all expressions. We saw PD-L1 greater than 50% and 13%, 1 to 49%, 1 to 49% of PD-L1 expression, and 31%, less than 1% in 25, and the rest were not available data. But you can see here that the overall response rate was comparable to the previous study that I described at 56%. And so I think one of the big questions that we ask ourselves is, what is the durability of response, or what is the duration of response that sometimes checkpoint blockade can afford patients? And we see here a progression-free survival of 9.6 months and a median overall survival that has not yet been reached. So we're still waiting on that data, but ultimately we're hoping that there is some signal of durability that could potentially, maybe a potential smaller portion of the patients that were treated, that would ultimately lend itself to the inclusion of immune checkpoint blockade. And I wouldn't be fair to describe the study without talking about the double-edged sword that exists with immune checkpoint blockade. We're always looking at efficacy for sure, but we also want to balance that with the risk of toxicity. That doesn't speak to just immune checkpoint blockade. That is an appropriate determination for any type of additional agents that we add to standard of care. We want to make sure the risk-benefit profile makes sense. But what you can see here on the left panel, which is not surprising, is that the patients who had higher PD-L1 expression seemed to do much better than those with intermediate or negative expression. You can see those with a PD-L1 greater than 50% had a PFS of about 17 months, as compared to 10 months and 7.5 for the various subcategories. So this really speaks to biomarker-driven approaches to therapy. And so for patients who have a higher PD-L1, this may be a reasonable option to explore going forward. And again, we want to balance that out with the risk. So this study reported 101 immune-related adverse events, including 17% grade 3 or higher toxicities. And those toxicities are listed above here in this table. You can see hepatitis, diarrhea being very common, interstitial lung disease, being also a common side effect. But even so, grade 4 pancreatitis was presented, which again represents some, and grade 4 skin toxicity, which really represents some of the double-edged sword aspect of doing immune checkpoint blockade in this patient population. Though I think there is a place for it in the treatment of thymic carcinoma. So just to kind of wrap things up and go through some of the key takeaways, the treatment landscape for metastatic disease and even going into neoadjuvant and adjuvant approaches is evolving with both frontline management and beyond. I'll reference the recent webinar that was done on May 6th, which really delved into a lot of the exciting trials that are on the horizon for managing advanced and metastatic thymic tumors. I can't emphasize enough the idea of a multimodality and multidisciplinary approach to treating these rare diseases. Oftentimes, it comes down to experience. It comes down to the expertise on hand. And so having a conversation as a medical oncologist, having a conversation with our thoracic surgeons, our radiation oncologists, our pathologists, and our radiologists helps us to identify really a personalized approach to what the best treatment is for an individual patient. And so we try to apply that through the framework of the guidelines and certainly the recent changes in the TNM staging. And finally, I'd have to point out that basic and translational science remains a crucial portion of drug development, and not just in the expansion of treatment options. I think we're always looking for more options for our patients, but certainly we don't want treatments that are just marginally beneficial. We truly want to improve outcomes. And so I think that should be a key point in how we develop drugs moving forward and bring them into the metastatic setting, and then certainly bring them forward into earlier stage disease. And with that, I'll stop sharing. I'm happy to take any questions. Thank you for your time.
Thank you.